welcome to Menopause Rescue. I'm Dr. Polly Watson. Midlife women are often caught up in a sea of symptoms. Too often, they're overwhelmed by the lack of support from mainstream healthcare. They're inundated with so-called experts who are selling solutions which may lack credibility. I'm a Menopause Society certified gynecologist with both traditional and functional medicine training. I'm here to guide you through this transition and help you decipher the facts from the fads. Armed with credible information, I hope you are empowered to rescue and restore your health, making the second half of your life your best. Welcome to Menopause Rescue. I'm your host, Dr. Polly Watson, and I'm so excited to have two fabulous folks from the Wisdom Study with me here today. So I have Dr. Tamandra Morgan and Allison Fiskalini. Dr. Morgan is a graduate of Stanford. She did her genetic counseling work at Hopkins Medical School at UIC Chicago, and then both OBGYN residency and the fellowship at UCSF. And Allison Fiskalini is the director of the Athena Health Network and one of the leaders in the Wisdom Study. So thank you both so much for being here.
Thank you for
Thanks for
having
having
us.
us. Yeah.
So maybe folks don't even know what the Wisdom Study is, but maybe we could just start off with what's wrong with current breast cancer screening as we're doing it now. Because I think a lot of women are just like, oh, I get my mammogram every year, and they don't realize that maybe that's not how other countries are doing it. So can you guys just jump on in with what are we doing with breast cancer screening in the United States and what's confusing about that?
Yeah, so I think when we think about the goal of screening for any cancer, particularly for breast cancer, the goal is to detect early stage disease in healthy patients. And by doing this, we can prevent bad outcomes, we can improve survival from the disease, and we can avoid the need for more intensive treatments. So, screening tests have both benefits and adverse consequences. Our benefits are, of course, early detection, leading to improved health outcomes. But some of the adverse consequences that we have to weigh against the benefits are the cost. We live in a capitalistic society. Healthcare is not a free commodity. So, there is a cost associated with everything, a cost to the payer system, a cost to the patient. Anxiety associated from screening results and the need to have additional screening, and just, of course, the inconvenience associated with doing these tests. There's also a chance of false positive results. So if you get a screening test and it tells you that there's something abnormal, and then that leads down another pathway of having to do more tests like biopsies, which can lead to overdiagnosis or overtreatment, we do really need to consider that when we think about who should get screening and how often. So what that has all really resulted in is different organizations have different opinions and recommendations about both the age at starting breast cancer screening and the regularity. So how often you should get screened, whether it's every year, every 2 years. In general, the most organizations, so we think about American College of Obstetrics and Gynecologists, the American Cancer Society, the US PTSF, Preventive Task Force Organization, they recommend starting mammograms for the average risk woman at age 40. So if you're an average risk, and we'll talk a little bit more, what does that mean? You should start getting an annual mammogram at age 40. And this has been shown to reduce mortality in breast cancer. But so I think what we really need to balance is who's average risk and who's high risk, and how do you know that? What are the tools that need to be implemented to determine risk assessment? Breast cancer risk assessment is very important for identifying who might benefit from more intensive breast cancer surveillance versus who can just do their annual mammograms.
So when you were talking about who's average risk and thinking about the cost of a false positive. So one of the things that was brought up when we were talking about wisdom at Menopause Society this year was the rate of false positives and the rate of looking at DCIS and early breast cancers or precancers that may or may not progress. And so it's a real trade-off, right? Because we want to detect all the breast cancers we can, but we also want to keep those numbers of benign biopsies where we saw something on your mammogram, we put you through the cost and stress of a biopsy. We want to not do a lot of those unnecessarily. And I think that's a real tricky balance. And so I think the wisdom study is really going to help us with that. So maybe, Allison, can you talk a little bit about how we're assessing risks so that we can do more invasive or more intensive training testing on people who are higher risk?
Yeah, definitely. So, as Tamandra mentioned, the guidelines that are out there are really just based on age. And we know that breast cancer risk can vary, and there are many other types of risk factors that aren't being taken into consideration in the current guidelines. And so, what we're trying to do in the Wisdom study is test a personalized approach to breast cancer screening, where we're doing a comprehensive risk assessment to try and determine someone's individual risk and then give them an individual recommendation for how often they should be screened based on that risk. So, um, the data that's being used right now to develop the guidelines is all old retrospective, data. And so what Wisdom is trying to do is conduct this prospective study where we're collecting data in real time and looking at outcomes to be able to provide data to support updated guidelines that can be more personalized. So in our personalized approach, we take into consideration your age, your race, ethnicity, your family history, your biopsy history. If you have had screening, what biopsy? If you had a biopsy, your breast density. We look at, with the new model now, your BMI and your menopausal status. And then one of the most innovative pieces of the risk assessment is genetic testing and genetic risk. And so this is an area that most of the time, if you were to talk to your provider about getting genetic testing for breast cancer, they'll only recommend and order a genetic test for you if you've had a first-degree family member diagnosed or you have a strong family history. And what we're doing in the study is offering genetic testing to everyone, regardless of their family history. And really, again, to try and understand underlying risk and to see, maybe that criteria of a first-degree family member isn't a great criteria, and we should be offering it to everyone as a population-based test. So again, taking all of that information into account, and with the genetic testing, we're looking at not just breast cancer-related genes. We've just now expanded to some additional genes related to other cancers. But again, another innovative piece is looking at what we call polygenic risk. So it's small changes in your DNA, in SNPs that everyone has. We look at over 10 million SNPs, or we're gathering over 10 million SNPs and putting those into a polygenic risk score, which can help us to see if you might have underlying hereditary risk, but not a genetic mutation. And for some people who have a really high polygenic risk score, we'll tell to screen more regularly because that means you do have a higher underlying risk. So taking all these pieces, putting them all together as part of this comprehensive risk assessment and telling women, recommending how often you should be screened. And if you are at high risk, also suggesting other modalities of screening like an MRI to help supplement those mammograms.
I remember at NAMS this year, they were talking about how often you guys were seeing some of these, I don't want to use the word mutation, genetic spelling mistakes in these genes that increase our risk with people with no family history. And so I think a lot of women come in and they think, oh, I don't have to worry about this. I don't have a family history of breast cancer. But most breast cancer isn't inherited. And then in your study, didn't you guys find that a significant portion of folks were having some of these abnormal gene variants, but had no family history? So can you talk about that a little bit more?
Yeah, so I think that's what's great about the wisdom study. It's really looking at a personalized risk assessment. And so I think about what we've seen so far in the data. Close to 70% of the participants did not have a first degree relative with cancer, but they were found to be a carrier for a mutation. And so these are patients that potentially would not have gotten genetic testing had they gone through, normal risk assessment through their provider. And so by testing patients as part of their participation in the study, we were able to uncover people who have a genetic predisposition for breast cancer, but their family history would suggest otherwise. And so that's why I think this is such a powerful study to be a part of, because we're really gaining knowledge about people's personalized risk assessment and really tailoring and targeting our recommendations for screening based on that.
Absolutely. And then, also maybe that might in effect lower some of those false positives, because when we're doing the more advanced testing with a greater filter, if you will, we're focusing the higher risk screening on folks that have a higher chance of having the disease. And so that's going to lower false positives. So this is just such a fantastic thing that we can all do for ourselves, but also for our daughters, right? I think it was mentioned at the conference that we're kind of following, what was it, like 1980s medicine? Like it's really time for an update here. So this is such a great opportunity.
Yeah. And one thing just to add in too, and you mentioned your daughters, you know, usually the guidelines recommend starting to screen at 40. And because, many people may have a mutation but don't have family history, our goal now with Wisdom, we've lowered the enrollment age down to age 30 with the goal of trying to find women who are younger than screening age, who may be at high risk, so that we can identify them, offer risk reducing options, and be able to start their screening earlier and provide enhanced screening, so that hopefully if they do develop a cancer, it's either caught early, or the best scenario would be it doesn't develop at all if we can intervene with risk reducing strategies. So that's also a really important part of what we're trying to do, is to make risk assessment sort of the starting point of the discussion around screening, and to do that risk assessment to help guide those decisions. And we can do that at younger ages. We don't have to wait until 40 to have that risk assessment complete.
Yeah, absolutely. Dr. Morgan, can you talk a little bit about kind of going back to Allison's point about younger women? So, mammograms are really pretty good at picking up slow growing disease that presents with microcalcifications. And I think that sometimes folks feel like, well, my mammogram missed my cancer. And maybe they don't understand that mammograms don't pick up all kinds of cancer well. So can you kind of talk about maybe that younger patient a little bit that might present with breast cancer and why her disease may or may not be picked up on mammography?
Well, one thing that we know is like nearly half of all women have dense breasts, which may increase their risk for breast cancer. And we also know that mammograms before the age of 30 aren't recommended. There's not the preferred screening modality. We think about breast MRI. There's not great evidence, meaning the organizations like the U.S. Preventative Service Task Force does not have evidence to recommend for additional screening for patients who have dense breasts or for women younger than the age of 40. So they really recommend that more research needs to be done to figure out what additional screening modalities and like at what regularity should we be offering both younger women, women with dense breasts, to help find cancers at an earlier stage. And so Wisdom Study does take into calculation breast density when we're making our personalized risk assessment. But for instance, for patients who are at high risk for breast cancer, whether due to a genetic predisposition, like a inherited mutation in the BRCA1 or 2 genes, we do recommend screening modalities that alternate with breast MRIs with mammograms at certain frequencies for women under the age of 30 and over the age of 30.
Mm-hmm. There are more tools available. Breast MRI is really helpful. And I think this is so important. Again, most of us are getting that sentence on our mammogram report that says, you have dense breast, your mammogram may miss disease, go talk to your doctor. And then they come back to their doctor and the current guidelines are go fish, right? Like go fish. And I loved at Menopause Society this year, the Wisdom Group, I think they put up a slide that said screening breast ultrasound has 90% false positive rates, because that's what women come in and ask me for. They say, I have dense breast, I want a screening ultrasound. I'm like, I think we're setting you up for an unnecessary biopsy. We can talk about doing an MRI, right? But a screening breast MRI still has a 40% false positive rate. So this is where Wisdom is really going to help women make sense of that. I have dense breast. What do I do about it? Well, let's get some more information. Let's get that polygenetic testing. Let's look at your BMI and all these other factors. So it's just really a great way to turn some of this anxiety around breast screening. Let's use science instead of fear, right?
Absolutely. It definitely empowers patients to have a really personalized and informed approach to their screening.
Mm-hmm. Mm-hmm.
One thing to point out too that you talked about, my mammogram missed my cancer. One thing that we also know from another trial that we do called the I Spy trial is that the majority of women find their cancers themselves. And there are different subtypes of breast cancer. Cancer is not one disease. Breast cancer is not one disease. They grow at different rates. There's the slow growing cancers. There's the very aggressive cancers. And a lot of those cancers pop up in between regular screens. And so it's super important that women know they're normal, know their bodies, and can seek help and be empowered and be an advocate for themselves to go seek out additional screening and testing if there is something that's different, even though they just had a normal mammogram. So regardless of a mammogram or a risk assessment, that is a key part of what we try to emphasize in the study as well.
This is all fantastic. Maybe we could kind of tell folks what they get when they participate, kind of what's involved. Because I did it. I thought it was super easy. I think you guys have set this up so well. And anyway, tell people how they can join.
Yeah. Well, I'm glad it was easy for you. We've been very hard at work to try and make it as easy as possible. So the study is open to any woman across the country, anywhere across the country between the ages of 30 and 74. And you can sign up on our website, which is thewisdomstudy.org. You'll fill out a registration form, create an account. You'll be asked to choose a study group. You can choose the personalized arm, which is what we've been discussing, or the annual arm, which is basically just getting an annual mammogram, not the comprehensive risk assessment. You'll do an online consent form, fill out a baseline questionnaire. And then if you're in the personalized group, you'll receive the genetic testing kit in the mail. You spit into a tube. There's very clear instructions. Mail it back in a prepaid envelope. We ask you if you've had a mammogram to upload your report so we can get that breast density value to put into our risk assessment. We take all that information and aggregate it in our comprehensive algorithm and then provide you back with a screening assignment letter that tells you what your risk is and therefore your screening recommendation. It also gives you back your genetic testing report and gives you access to an online breast health decisions tool, which can help walk you through your risk factors, what puts you at high risk, low risk, etc. For those women who are found to be at high risk, we connect you with one of our breast health specialists and you get a consultation via phone where you walk through your risk factors and what our suggested next steps are. And then every year that you're in the study, we ask you to complete a yearly questionnaire. And based on those updates, we'll update your risk assessment and give you a new screening assignment. Risk can change over the years if you have a biopsy or a family member gets diagnosed. So we want to continuously stay in touch so we can update those screening assignments and give you the most accurate information possible. So everything's no cost. Everything is covered by the study, the testing, the consultation. So again, we've tried to make it as easy as possible and to provide as much information back to you as the participant so that you can then take that back to your provider, have a discussion, and be able to set up a screening plan based on the information we've given.
Absolutely. And you guys have done a really great job. A lot of studies have not looked at populations that mirror the population of the country, right? And so in the preliminary data you guys showed at NAMS, you've done a great job about recruiting folks that are all different kinds of folks from different racial and ethnic groups, socioeconomic groups. Does anyone want to talk about that? Because I think that's really important. A lot of times folks come into my office and they say, well, we're talking about a study, and they might say, well, am I represented in that study? And a lot of times the answer is no. And so I think that's a really important to bring up because it's unique and it's the way medicine should be.
Yeah, I would comment that, as Allison mentioned, breast cancer is not just one disease. And we do see variations in different patient populations. Particularly, what we've seen with Black women is that their breast cancer diagnoses tend to happen at later stages. They have a higher mortality, although they have a lower incidence compared to white women. And so a lot of that is related to unequal access to healthcare systems and inequalities and healthcare outcomes. But I think what is the hope of the study is that we can learn how to better personalize treatment and diagnoses for Black women. So whether that's recommendations for earlier um, screening timelines or using different modalities, it's very important because there's a huge inequity in outcomes for breast cancer among minority populations.
Yeah. And just to add to that, for wisdom, the study's actually been going on since 2016 is when we enrolled our first participant. And a few years into the study, we realized that our population was not representative of the underlying US population. And so we um, applied to and received an additional grant to really focus on outreach and engagement and trying to ensure that our cohort was reflective of the underlying population. So we reached out to new recruitment centers across the country that served more diverse patients. We found new partnerships with community organizations and worked with the VA, which has been a huge contributor to our racial and ethnic diversity in the last few years. We've made huge improvements, and the numbers are much better. Um, we're also, as part of the polygenic risk score that I mentioned, there are different ways to assess risk based on ancestry, and so that's another place where we're trying to personalize the information we're giving back based on ancestry. And you're absolutely correct. The data that we have to go off of is based off of studies that were not very diverse, and so in the risk models that we have, the risk model we chose for wisdom was also very intentional because it was based on a very representative cohort of 1 million women across the United States. Most models are based on a European cohort. So we've been very intentional about trying to make sure that we're not only using the more representative data sets available to us, but we're also contributing back to that and improving the field as well by including a more diverse participant population in the study as well. So we want to make sure that the results and the information that we're giving back is reflective of someone's individual risk.
I love that with if you do, maybe people are out there listening and thinking, oh my God, well, I'm afraid of what I'll find out, right? I think if you do the testing and you are in this higher risk group, you will get to speak with someone from the wisdom study because like my mom got diagnosed with breast cancer last year and she's 76 and her doctor did genetic testing and like I've been practicing OBGYN for over 20 years. Like we knew about BRCA1 and BRCA2 and that was all I knew about. Okay. And so I'm like, why are you testing someone who's 76? Women with genetic causes of breast cancer get breast cancer early. And she turned up, she had the ATM mutation. I'm like, what the heck is that? Right. And so I guess what I want to say is that we're learning about new genetic differences all the time. And your OB-GYN or your primary care may not be familiar with these. So if you're in this study, you have an opportunity to meet with someone who does have training on these newer variants that many of us are still learning about.
Yeah, and thanks for that example, Dr. Watson, because now the American Society of Breast Surgeons recommends genetic testing should be available to any individual with a personal diagnosis of breast cancer. So we're really expanding genetic testing recommendations. And like you said, finding out that you carry a predisposition has many implications for your own personal health, but also your familial health. And you can really take that information, empower yourself to provide preventative and risk reducing strategies. So that might look like risk reducing surgeries, mastectomies before any signs or development of cancer, or taking risk reducing medication. So tamoxifen is a medication that we recommend to reduce your risk of developing future breast cancers. And this is all strategies that you can take that if you didn't know you were at higher risk, you would have never known to ask about it or to consider these options.
Or to have different screening also, right?
As well.
So
Yes.
you might be someone that might need an MRI in addition to your mammogram. That's still confusing to me. When people have extremely dense breasts, I found some papers in Germany where they were just doing MRI every 2 years. And, if you kind of have that white on white, extremely dense breast, mammogram, why are we doing those still? Why aren't we just doing MRI? Can anyone answer that for me?
No, that's a good point. And there are other imaging modalities that are out there that they're trying to test and become more mainstream. Contrast enhanced mammography, having that contrast in an image is much, much better and much more helpful. But yes, I mean, I think that's something that we're trying to improve upon. Abbreviated MRIs, MRIs they take a while, they're expensive. Not everyone can tolerate the contrast, the IV contrast. So again, trying to improve the way in which we can screen women with dense breasts. And like you said, ultrasound is not the solution.
Right.
So I was going to add on though, you had mentioned taking the information back to your doctor, and Tamandra mentioned tamoxifen. So one of the things that we're also trying to do is work with primary care providers, OBGYNs, who maybe aren't as familiar with breast cancer risk and risk reducing medications. The idea of tamoxifen, most people will think of the standard 20 milligram dose and hear stories of women who weren't able to tolerate it, had horrible side effects, but there's a lot of evidence now to support using low dose tamoxifen, which is much more tolerable with the same risk reducing effects. And a lot of local providers don't know that. And so we're trying to also provide educational materials back to providers so that they know that these options are available to their patients. And there are options that women tolerate much, much better than they did in the past.
Oh, that's fantastic. Because I think a lot of us hear tamoxifen and think, no, thank you. Like it just in terms of sexual health, joint pain, pretty significant side effects. So 20 milligrams was the dose I grew up with, right? And the lower dose, which has still been shown to be effective, is what?
5 milligrams.
Huh?
Yeah, there are some studies that have shown 5. Some people will say 10, but the same studies have shown the same effects at 5 milligrams as well. It's called low dose, or sometimes it's called baby tamoxifen. So,
and do we have any data on sexual wellness with that low dose? I mean, I would think that you could still give a concomitant vaginal estradiol or a vaginal DHEA to sort of blunt that vaginal side effect of everything drying out with the tamoxifen.
Yeah, I would have to go back to the original paper. I know that most, if not all, of the side effects were very much blunted, but I'm not sure about the combination. Yeah.
Okay.
Yeah.
Okay. That's great to know. Thanks for sharing that.
Yeah.
Thank you both so much. Anything else anybody else wants to shout out before we wrap up?
I would just encourage patients to feel empowered to talk to your doctors during your visits. Just ask them, what should I be doing about my breast cancer risk assessment? And there's, multiple online calculators out there. There's a lot of different ways to figure out like what your risk is. And I think for your own interest, exploring the Wisdom Study website and just enrolling in the trial and getting more answers to these questions, I think that would be my recommendation for everyone out there.
Yeah, I would agree. I mean, I think for the study, you're getting something back personally. You're getting a risk assessment and all of the information back, but you're also contributing to this study that will hopefully be guideline changing and practice changing, and will really help to bring breast cancer screening and prevention into the 21st century, and personalize screening and prevention care. We always talk about precision medicine, and we're doing great with treatment. Treatment is getting so much better and survival rates are improving, but we need to kind of focus back to screening and prevention and do a better job there. So the Wisdom Study is a great example of how you can not only help yourself, but help the greater scientific community.
Yeah, I don't have daughters, but I'll do it for y'all's daughters. And maybe I'll be a mother-in-law to a daughter one day. That would be really cool. So let's do it for ourselves, but let's also do it for the next generation.
Absolutely.
Exactly. Yeah.
So thewisdomstudy.org, it's free. Sign up. You're doing something for yourself and the next generation. So thank you both so much. This was fun. I enjoyed it.
Yeah, thank you so much for having us. We really appreciate it.
Yes, thank you.
Yep.
Bye.
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 Thanks for listening to Menopause Rescue. We hope you've enjoyed this podcast and it helps you create some time and space to make this the best half of your life. If you've enjoyed this content, please leave us a 5-star rating and review. This helps other listeners find this resource and rescue and restore their health. If you enjoyed this topic and want to learn more, check out our resource guide for this episode. If today's podcast resonated with you and you want to take a deeper dive, check out my educational resources. We offer basic membership, which is an archive of over 100 videos on menopausal topics ranging from bone health to libido. We add to this archive every month, so the resource becomes richer and richer over time. If you're looking for a menopause expert and live in North Carolina, take our free online class and see if we're a match for your needs. It's called Are We a Good Fit? And is a quick and easy way to learn more about our practice and what it has to offer. Hey, this is Dr. Watson. This is just a friendly reminder that this podcast is for general information purposes only and does not constitute the practice of medicine. No doctor-patient relationship is formed, and any information you get from this podcast is considered educational only. You should make medical decisions with your healthcare provider. The content of this podcast is not intended to be a substitute for professional medical advice. Listeners should not disregard or delay in obtaining medical advice for any medical condition, and they should seek assistance from their healthcare professionals.